Hi, I'm Bob Wigton, and we're here today to interview Jay Moore, who is the Associate Dean for Academic Affairs and has had a very distinguished career at the College of Medicine, and also we were good friends as medical students, residents, and so forth. Jay was a member of the class of '71, and I guess we could start off with some of your thoughts, reminiscences about your class and your career and how you got into academic medicine.
Okay, sounds
Just
good.
in a word, yeah.
Just in a word, yeah. Well, I joined the class of '71, as you said, and I was fortunate enough to be one of a select group of people. There were 90 of us in the class, of which 9 were women, and the other 81 obviously were men. That's changed quite a bit recently. We're about 50-50 with men and women in the class at the present time. We started out, Whitson Hall was not here, of course. It was just the North Lab and the South Lab. And we had our anatomy on the 6th floor of the North Laboratory. I remember that because it was a semester and a half long, and it was very cold because we had to have all the windows open for ventilation. So it was always exciting to try to figure out what to do to keep warm. One of my classmates wanted to make some money, so he was bringing up a cooler with ice and to sell pop. And he was pretty much told that's not going to happen, so we lost that. But we had great fun. It was a lot of interactions with the faculty members, a lot of one-on-one because of the smaller size of both the class and the faculty at that point in time. So there's some very dedicated teachers, as there continue to be at the present time. So the first 2 years were standard, I think, mostly lecture and laboratory. No small groups at all. It was very interesting to learn physical diagnosis. On the wards, when I first started, there were still wards of 30 to 50 beds, the men's ward and the women's ward. And they were, we had one examining room, so we brought the patients into that examining room and had 4 or 5 of us examine the patient at the same time. It's rather different than what we do now at the present time. But it was back in the old hospital. Of course, while I was in medical school, they started building Whitson Hall. And so the class, I think after me, 1 or 2 years were the first people that were starting in that class for classes. The junior year, I had the standard rotations. And I remember at that time I was in Douglas County Hospital for surgery. We used to stay overnight and run the emergency room because there were no full-time physicians available, so that was quite an experience. I remember one time I was called to see a patient down the emergency room about 5 in the morning. And the patient, I said, "What's wrong?" They said, "Well, the police are bringing him in," but he said he was walking downtown and saw a flashlight, said, "Turn the flashlight out," and then the train hit him. Amazingly enough, he didn't have very many significant findings on his physical exam. He must have just got brushed by the train, so it's funny. Back then, on medicine, I was at the VA. I remember distinctly that our senior resident was only interested in studying for boards. And so he didn't make rounds with us on a regular basis. The students were pretty much in charge. That certainly has changed as well for the present time. During the senior year, I didn't really know what I wanted to go into. So I went through the process of applying to different places. And back in those days, I didn't have very good advice, so I didn't go interview any place. But I still got my first choice, so I was happy with that. Spent the year at Bronson Hospital in Kalamazoo, Michigan, doing a rotating internship. Had probably 125 deliveries under my belt. 75 of those, I was the primary physician, so it was a pretty good experience. The emergency department, pediatrics, all the standard rotations. And then I didn't know what I was going to do because back then there was a draft, and I was eligible for the draft. I was classified 1A. So I went for a physical, and they said, unfortunately, if you hadn't been a physician, you wouldn't be eligible. I said, why? And he said, well, you've got a hernia. I thought, damn, I just went to medical school for the wrong reason. No, I'm kidding. Anyway, I didn't know what to do, so I called back here, and I talked to the chief resident before you. Who was that?
It might have been, let's see, right before me. Hazing.
Yeah, John Hazing.
Yeah.
Anyway, I talked to him and I said, do you have a place for me or have a suggestion? He said, I'll come in as a second year medicine resident. So I came in, and since medicine was 3 years long, I ended up doing the chief residency after you finished after 2 years doing that. So I took over there and had a chief resident at the VA, Merle McAlevey, and had a good time from that standpoint. Then I stayed here on general medicine staff. So I did general medicine for some time. And then about late 70s or early 80s, the only rheumatologist in town left. And so we had a rheumatology clinic that was once a month in orthopedics clinic. And the chairman of the medicine at that time said, well, you're chief resident, you don't have anything better to do. Why don't you run the rheumatology clinic? So I ended up doing the rheumatology clinic with the vice chairman of the department, who was an infectious disease doctor. So a generalist and an infectious disease doctor did rheumatology with orthopedics for a couple of years. Ended up when Jim Odell and Lynn Clausen joined the faculty as the first rheumatologists, they eventually suggested that I might want to get training in rheumatology. So I spent a year at the NIH doing some clinical research. Then came back here and been here ever since.
That's interesting. What was the name of the rheumatologist that left? I don't remember it.
Yazıcı, Hasan Yazıcı.
Oh, sure, sure.
He was from Turkey.
Yes, and he was the guy that's famous for his articles in one of those diseases that's prevalent in the
Behçet's.
Yeah, Behçet's, right. He became an expert on
We
that.
actually had his son come here as a visiting professor a few years back, so
Interesting.
very interesting.
So when did you get into the dean's office, and why?
Yeah, why? There's an involved story there. Unfortunately, I was volunteered to, fortunately, I volunteered to be on the curriculum committee. And this was back in about 80s, 78, 80, something like that. I was on the curriculum committee, and we decided we were going to look at the curriculum in the second year and analyze it and see whether it could be improved. And at that time, there were a lot of little courses, 2 hours here, 3 hours there, 1 hour. And I said, why don't we consolidate that all into one course called Introduction to Clinical Medicine? And they said, well, fine, why don't you run it? So I ended up running this course.
Oops.
Yeah, oops, this is the exact correct answer. So I ran the course for several years. And then I went to the NIH, as I said, for 1985 for a year. And when I came back, Bob Waldman was here as dean. And he asked me if I would be interested in becoming assistant dean for curriculum. So that's how that happened. And then I've been in that position or something like that ever since that point in time. So I've been involved in a lot of the changes that have occurred in the curriculum over the years.
Now, say something about the evolution of the curriculum.
Well, actually we have some pictures of the curriculum in 1900. I think you've created some of those, and especially the one with the stagecoach and the bones, that they're standing outside, and the scrum for the football team that we used to have. It wasn't quite that bad when I was there, but we had classes, standard classes in biochemistry, physiology, anatomy, etc. I remember the histology class was in the amphitheater in the North Laboratory, and there was a chalkboard there, of course, and the histologist came in with his colored chalk every morning for 15 minutes, putting the schema on the board. And so some of us, not me, but some of the people in the class ended up going to 15 minutes early, so they had all the colored pencils out and they copied all that. It's a little different from what happens now. But as I said before, it was mostly lecture and small group, and not small group. And laboratory experience was very important. Physiology Laboratory, where you did experiments with gastric acid, and cardiology for exercise-induced disease, et cetera, et cetera. So it was a good experience. I didn't go any different at that point in time. And as I said, things evolved into many small little courses, but they were still basically discipline-based. So anatomy, physiology, plus the clinical medicine course that I taught, which is the physical diagnosis primarily.
And they often followed a book.
Right.
They'd have a particular book, as college courses did.
Right.
And you'd have chapter 1 for a certain amount of time. And
exactly right.
so the organization was fairly standard just because it followed the different
textbook,
books.
yes.
Textbooks, yeah.
And most of the instructors were not clinicians. In fact, I would say a very minority of the instructors in the first 2 years were clinicians. We didn't notice any difference because we didn't know that clinical medicine really existed until our third year. Then third year we had, probably the thing I remember most about that is the family medicine rotation I did out in Aurora, Nebraska. We stayed in the hospital wing that was a nursing home. And one of my classmates and I were there in January.
Oh.
And two things happened. One is one night I got awakened about 3 a.m. with screams from my compatriot's bed. And it turned out one of the patients from the nursing home had wandered around and was climbing into bed with him. And so he decided. But the other thing that happened was that we had a snowstorm on a Friday afternoon, a blizzard. And it was so bad that a rescue squad came in with a patient with chest pain, and then they closed the roads, so nobody could get there. And I was the only physician-like person there. And the guy arrested in the emergency department. So I ran this cardiac arrest in the emergency department. Well, it wasn't really emergency department, it was just sort of a room off the... Yeah. And I did the code. Unfortunately, the patient didn't make it, but afterwards the nurses said, that was really exciting. I said, well, why is that exciting? That's the first time we've ever done a resuscitation. I thought, I'm not pretty much the right person to be doing that, I guess. Anyway, and I took electives during the senior year, and so it's pretty standard for that format. Then we made the change that I alluded to before to consolidate some of the courses. That was the next step that I think we noticed as much as anything. And then mid-'80s with Bob Waldman said we need to start looking at our curriculum when I started becoming assistant dean for curriculum. And so we looked at our curriculum at that point in time and said, what can we do differently than what we're doing now? And so a lot of the issues that we're facing today, or we were facing then, is how to get the students more involved, get rid of the passive learning, get more active learning. And we decided to try to consolidate things a little bit better and separate it out. So we ended up with a curriculum that the first year was, quote, normal anatomy, normal physiology, normal biochemistry, taught in that manner. And then the second year was primary pathology. And they were separated out grossly that way. We started using problem-based learning, which was very popular at that point in time. It was one of the, we weren't the first schools to do it, but we were one of the early adopters of that. And that was the beginning of using small groups as an educational tool at this institution.
I remember that.
Yeah. And it was good, it was interesting. A lot of the faculty reacted to this, why are we making this change? And basically, how do you prove that it's good and you're successful, et cetera? And we had a hard time answering that. And basically, the bottom line was, well, it got us to thinking about the curriculum. That's probably the most important thing we did. We applied for a grant from the Robert Wood Johnson Foundation, got a relatively small grant, but it was nice because it gave us a deadline of 1.5 years that we had to get the curriculum done and online. So that worked out pretty well. So we continued with that curriculum over the next 20 or so years.
This curriculum started in the 90s?
92.
92.
Yeah. Started in 92. And it stayed pretty much, the format stayed pretty much the same, but a lot of things have been added over those 10 years. A lot of things have made a difference. I mentioned the small groups already, using problem-based learning. Now we're doing something called TeamBased Learning, in which the whole class has groups in a classroom, and they go over some questions, pre-questions and post-questions, and the instructor helps them with that kind of stuff. We're doing virtual histology and virtual pathology, which is taking online electronic slides of the tissues, and the instructor can control the computer and draw the circle around the cell that they think is the most important. We don't use microscopes anymore, so I don't think our students know how to use them from that standpoint. The anatomy laboratory has become computerized. That's been a major thing, so they can also control the screens at each table. Each table of 4 to 6 people have their own computer and projector, so that works out pretty well.
This is where the synthesized body is lying as electronic in the...
Well, yeah, we don't use that as much in the medical school. They use that more in allied health right now in teaching, but that's one of the newer things that are occurring. We can talk about technology for a long time.
Sure.
There's a lot of new things with that. We also were one of the early adopters of the OSCE, the Objective Structured Clinical Examination, in which we said earlier clinical exposure, either through the standardized patients or using mannequins or something like that, would give people an opportunity to practice on a non-human, so to speak, but it's relatively lifelike. And then be able to go into the wards and have a little bit more feeling for what's happening and how they should be treating the patients. We spent a lot of time talking about history and physical examination. How do you deal with a difficult patient, the patient needs a translator, underprivileged individuals, and how do we handle that, those that don't have financial support and things like that. So that's been good from that standpoint.
Could we go back a ways and say a little bit about the 3-year curriculum?
Yeah, okay, good thing.
Were you involved in that at all? Or?
No, I was not involved in that. That started about 1972 and went through 1980 or so. So what happened was the idea was to consolidate medical school down from 4 years to 3. Basically all that happened is we eliminated all vacations. It sort of made it a little bit more intense. The first year we did it, we have a 4-year class and a 3-year class, so we had to double up the amount of education we were doing for that. And in reality, we got a lot of extra physicians out that year because we doubled up.
Yeah.
But then after that, it was just the same, as just came a year earlier than before. I think it was fairly successful. I've talked to people that have been through that curriculum, and they were happy with it. They didn't know anything different. They felt that they were well trained. But it got to be the point that it was too intense for people, and that's why we went back to the 4-year curriculum. And the doctor shortage was resolved a little bit.
The part of the stimulus was that the federal government was offering a stipend for every extra person you got out.
Exactly.
From the baseline in 72 or whatever it was. And that was disappearing too, and I think that led to maybe part of the I thought one of the big issues was that the senior students the 3rd-year students had to apply for residencies without as many clinical rotations, and I think they felt like they were at a disadvantage because of that.
Right.
But otherwise, I felt the same way, that they got the same training, basically.
Right.
It was just a little less vacation.
Yeah. No summers off. And
what do you feel about these changes in the curriculum, especially the big one in '92, where we went to a different reorganization with the cores and this sort of thing? What's the advantages? I mean, what have proved to be the advantages or disadvantages?
Probably the biggest advantage is what I alluded to earlier, and that was that we stimulated some of the faculty to do things in a different way. To think about it again. Unfortunately, some of our faculty like to use, in those days, the 2x2 slide set, and show the same slide set for 20 years in a row and not updated. So remodeling.
When I was in, there were just a couple people who actually used what's called lantern slides.
Oh yeah.
Big ones with you could type on them.
Oh, yeah.
You type inside. They were 2 pieces of glass.
Do you remember the overhead projectors and
Oh, yeah.
the rolls of acetate that people used and had to clean it off every time before their next lecture?
It was ubiquitous, especially for certain certain courses, certain disciplines would use that
Right.
a lot more. And,
For younger people listening to us talk about this, they probably don't know what we're talking about.
oh, that's right.
It's a little bit different than it was.
Well, in fact, I caught the tail end of using these big carbon arc projectors
Oh, yeah.
in the rooms. They were 2 pieces of carbon, and then you got them. You sent an electric current through them and got them at the right distance from
yeah.
each other, which usually only the chief resident knew what the distance was. And a gigantic light would project for long ways. And they had those in the North Amphitheater. The other thing they had is they used a carbon arc projector to look the wrong way through a microscope, and they'd aim it at the screen and you could see the slides.
Oh, really?
Yeah, the guy could manipulate the slides and everything. It was
I remember my histology laboratories and pathology laboratories using a microscope, never have any idea what I was looking at. That's what the advantage of the virtual histology pathology we do now, because they can say, here's an arrow, here's this cell is the one that you're looking at.
We had to draw every cell and then stipple in all the cytosomes and stuff like that.
Exactly.
How about the new curriculum? What do you think that's going to achieve, or what's its purpose?
The last 2 to 3 years we've been looking at this, and what we're going to do is turn the curriculum and do a little bit more integration than what we did before. So all things cardiovascular will be taught at the same time. So basic anatomy, physiology, pathology, treatment, pharmacology.
Now the course did some of that, is that right?
Well, except they separated out, as I said, the first year was all normal without pathology, and the second year was mostly pathology, assuming you knew the normal. And so you might have, for example, we always talk about acid-base balance, and learning acid-base balance would be taught 3 or 4 different times in the old curriculum. You get it first in physiology, and then you get it again in pulmonary, you get it again in renal, and they each approach it a different way. And so what we're trying to do is consolidate that and say there's one big picture, and so get better information.
Yes, and the sympathetic nervous system was another example.
Exactly.
Come at you every 2 months to a different teacher and that sort of thing.
Yeah, and so the new curriculum is trying to integrate that more, and that's being important. We're also using more simulations. We have the Swirl Center, which opened in 2008. It's the first home for the College of Medicine, which is very important. And that's been a fantastic building for us. It has the small group rooms. There's 22 small group rooms that we can utilize for anywhere from 8 to 12 students and a faculty member. The 2 large lecture halls, but we have the simulation laboratory where we have mannequins and people can go down and practice, as we talked about earlier, practice how to do intubation or starting an IV, whatever the case may be.
Do you think that these changes are having any effect on student scores on tests or on their retention, or do we have any?
I have to be careful about this. Student satisfaction is better. There's no question about that. Earlier clinical exposure is happening. They're more involved in their curriculum. They're more involved in, they're not just passively taking notes as much, but we want to integrate that more and stimulate them more. We're going to do more interprofessional education between nursing, pharmacy, and
that was always kind of a loss that we didn't take advantage of that, I thought, because after medical school I was in physiology for a while getting a master's, and I would teach the other like nursing classes and physical therapy and things like that, and I thought, boy, there's a kind of a wasted interaction going on there, that these were bright people who had a different look at the same thing.
Exactly.
So, yeah, that's. I'm glad that's come up.
You know, probably the big thing that is happening is students are smart. I mean, they're obviously very smart, and most people say that they would not be able to get into medical school now compared to the students that we see coming across the boards, and that's probably true for me as well as other people. But our students are going to succeed in spite of us, but we can certainly get them to understand a little bit better the how of what and the why of things, not so much the actual listing of 25 causes of X, Y, Z, something like that. So making them more responsible for how they learn, how they find that information, how they ultimately take care of patients. I think that's going to be a big thing. In the curriculum in '92, when we did this, we had the introduction to clinical medicine and talked about patient interactions I mentioned earlier. One of the most impressive things was the faculty on rounds, on wards, when they first got the students to come in from what was called the integrated clinical experience at that time, that they said these students are thinking outside the box more than they used to. More about ethical issues and social issues and things like that. And that's very satisfying to be able to say that it's happening. But getting back to your original question about board scores or data that suggests that there's been a marked difference, I don't think we have that. And most studies that I've seen nationally are unable to show a major change. But it depends on what you're trying to accomplish. You know, teaching somebody how to research something rather than just giving them the facts is a different thing.
Yeah, after all, the students who make it into medical school already are very proficient in retaining and reading and this sort of thing, or they wouldn't have the good grades that brought them in. So it seems like that would be a really uphill battle to improve their board scores and studying the same material and so forth and so on.
We're very proud, as you know, USMLE has 3 steps to it basically. Step 1 is the basic science material, and our students do fine with that. Step 2, our students consistently do better than the national average with their clinical skills. We didn't see a change with the curriculum, but it didn't go down, so that was probably the most important thing. And then we go to the curriculum, the teaching physicians for tomorrow, which is the new curriculum that will be starting the fall of 2017, wherever we are now. In the fall of 2017, we will hopefully be able to integrate all these things a little bit more completely. Students will take more responsibility for their educational process. And
so you'll bring it in a class at a time? Is that what happens?
Yeah, so
first the
over
freshman?
4 years. So we're changing into 3 phases. Phase 1 is about a year and a half long. And during that phase 1, they will get a block of hematology, oncology, a block of cardiology, pulmonary, et cetera, by organ system. Then we'll have, at the end of that time, we'll have what we call synthesis blocks. I'll get it eventually. The synthesis blocks are certainly areas where we get people for 2 weeks to get a case and sit down and think about issues related to what they've learned before, how do they evaluate, how do they take care of the patient. So they have to think and put everything together, hopefully, at that point in time. Second phase is traditional clerkships, which we've already had well developed and they've been very successful. And then the third year is the preparation for residency. We're requiring a lot more things. We've required basic life support, advanced cardiac life support, a section on quality. We're training students to do ultrasound at the present time. We're doing the simulated patients, as I said, and learning how to do procedures, and hopefully using the ultrasound can do things like IVs and different possibilities from that standpoint. But more importantly, they'll have what we call a capstone project that will take some subject and put it together and develop I think you had to do a thesis, right?
A doctoral thesis.
Doctoral thesis.
In fact, ours was the last year.
And mine was the first year that didn't have to, or something like that. Yeah, so.
Lucky.
But we're going to do something like that again. Yeah. And then people that are going into surgery or OB or internal medicine would spend several months with a curriculum that's developed by that department as a preparation for the boards, but also preparation for the residency. So they'll have a lot better training rather than sort of catch as catch can.
Well, that'll be interesting.
Yeah, we'll see what happens with it. It'd be interesting to see how this all works out. There's a lot of details that we're still working on. So,
looking ahead, do you see any major shifts coming up? Because there's so much change in the provision of medical care, and so much argument about that. Do you think, are we going to make a big change, or is this just
well, part of what we're doing is integrating that into the curriculum, more systems subjects. So how do you run an office? How do you take care of Medicare, Medicaid? How do you deal with insurance companies? How do you improve the health of the community? Working with the College of Public Health and putting that together is going to be something that looks at the bigger picture, the more the health of the community. So I think that's going to be important. I think there's all sorts of opportunities for us to improve and stop what you and I went through medical school. I think it was about how much knowledge can you jam in here and regurgitate back on tests. And we're going way away from that. Everybody has their own smartphone, and you can look it up on the smartphone just as easily as to cram it in the head. But how do you think? How do you problem solve? How do you do things? So we're going to be emphasizing that more, and I think we're going to see a big difference with people from that standpoint.
That'd be very interesting. There was a chair of medicine at at one of the New York universities. Eichner was his name, who went back and took medical school again at age 81.
Yeah.
He wrote an article about his experience, and I think the biggest thing I remember from it was that he thought that they had given them too much detail and not enough thinking.
Yeah, exactly.
And
the other thing is medical school is much easier the second time around. When you know medicine, it's much easier to do. So people have talked about having a pre-medical school.
Yeah, but taking call at that age, I don't know.
Yeah,
that would be something else.
That's true.
Well, you've, been the leader here in curriculum for, 30 years or so. It's an amazing record of that. Has that been fun? Would you do something else?
Absolutely.
Yeah.
I always tell people the big advantage of my job is I have multiple things to worry about. So there's always something to challenge you and get things. Sometimes it's people call me to say the lights don't work in this room. Can you fix it? But most of it is more substantive questions about curriculum. Probably the biggest thing for me is no doubt working with the students. I mean, this is so pleasant. I'm just totally amazed every time I sit down with a student and not worrying about the medical aspects so much, but talking about who they are and how they've developed and what they're bringing to. There's some very, very interesting stories out there from the medical students, and they're all. It's so much fun to see them as residents, and then as faculty when they join. Some of them join and see how they mature and develop over the period of time. And universally, when we survey our graduates, they're very satisfied with the educational process. Since we're a state institution, one of the goals is to increase the number of primary care physicians in the state. And we're certainly trying to do that as well as we can. We're rated in the top 5 to 10 nationally for that. Over 50% of our students enter into primary care residencies. They may not all finish them, but that's been very positive.
Yeah, this has been a tremendous change, because when we were in school, we were just leaving an era where half the students from here went into general practice.
Right.
And the family practice residency didn't come until 72.
Right.
So this was a completely different kind of training for readiness. You after your year after medical school, you had to be ready to go out and take care of anything.
Yeah, and many people did that.
And they did. And so
scares you now, but
been a tremendous change in the orientation of the medical school and what they want to prepare people for and so forth.
I thought there's another area I wanted to talk about is we do something called EMIT, which is Enhanced Medical Education Training. for students that want to sign up for a special sort of a special field. They go to all regular medical school, but they do in addition.
Ah.
So we've got one in geriatrics, one in immunology, one in HIV-related diseases, another one in community health, things like that. And those are people who really want to put the emphasis on a special area that gets a little bit of special training. It's very good.
That's great. Well, Jay, thank you very much for being our guest, for
All right.
talking about all of this. I think
Enjoyed it. Thank you.
I think people will find it all very interesting, because I don't believe in general there's a lot of understanding of how the curriculum has evolved over this time, and it's good to have you fill it in.
All right. Thank you.
Great. Thanks a lot.